and chair of the Department of Family Medicine and Community Health at Mount Sinai. And it is my great pleasure this morning to welcome Dr. Anne Marie Sullivan, who's Commissioner of the New York State Office of Mental Health, an office that she's held since 2014. And as many of you know, she's guided the expansion of community-based treatment, investing hundreds of millions of dollars in community services, enabling individuals living with serious mental illness to live successfully in their communities, and has sponsored and developed with her staff a huge range of programs to serve the mental health needs of New Yorkers. I had the pleasure of hearing her present on her very broad vision of both the mental health needs of New Yorkers and also the programs that have been developing in New York. And it was that stimulated our invitation to her, as well as her incredible advocacy during COVID for making sure that providers of behavioral health services continue to receive reimbursement at their full rate, irrespective of whether or not people were on audio visual, something that we tried to use as a model for the rest of the healthcare system, but not many people were as responsive to this, but it was really life-saving for those of us who have large footprints in behavioral health. Major initiatives that Dr. Sullivan has overseen have included the integration of physical, mental health, and substance abuse in care and treatment, something that the Institute's been involved in for many years, integrating prevention, wellness, and the social determinants of health in service delivery, reducing disparities in care, and enhancements in the criminal justice system that diverts people living with mental illness from going back to jail and prison after their release. Dr. Sullivan's also overseen an expansion of critical programs, including Zero Suicide, which we participated in, the first episode psychosis teams, which we've participated in, crisis intervention services and school-based clinics, which we have. Working closely with all mental health providers and health plans, she's guided the movement of the health benefit for the seriously mentally ill into managed care. She previously served as Senior Vice President for the Queens Health Network of the New York City Health and Hospitals, Director of Psychiatry at Elmhurst and Queens Hospitals, has taught, lectured, and published on best practices in community care, and is an active advocate for all patients and for her profession. She's a distinguished fellow of the American Psychiatric Association, serves as Speaker of the American Psychiatric Association's Assembly on its Board of Trustees, and is also a professor of psychiatry here at the Icahn School of Medicine, a fellow of the New York Academy of Medicine, and a member of the American College of Psychiatrists. I am absolutely thrilled that you were able to join us, and really look forward to your comments and to taking some questions at the end. So thank you for being here.
Thrilled to be here because I realize the tremendous work that you all have been doing for so long for behavioral health, for truly integrating behavioral health care. And it's just fantastic. So I can't thank you enough. You are leaders in really making sure that there's whole care for the patients that come to us, and making sure that behavioral health and substance use. I'm going to be talking primarily about behavioral health, mental health, because we still have two separate agencies, but I do want to say that we integrate intensively, and just like you are, mental health and substance use. So again, first of all, thank you all. Thank you all. I wanted to just go through this part quickly. You guys all know this, so I'm going to go through it quickly. And then I'm going to talk about what I think is the most impressive investment in mental health care that I've ever seen this year. And I don't always say that. I've been in government for a long time, so I don't just say it because I'm in government, but I do think it's an attempt to fill gaps that we've all been struggling with for a long time. And I hope you see that as we go along. So the current challenges are obviously the post-pandemic. You know, mental health issues often lag past disasters, as we know. So this increasing, an ever increasing number of individuals coming for mental health care, we're not sure when that's going to stop, but certainly the numbers are up. The numbers, the incidence of depression, the incidence of anxiety, and the press on the system for services is going up, up, up. I think one of the things we also have to remember, and why we're emphasizing so much youth care, is that the parents and families, you guys are probably much more attuned to that were lost to youth across New York State. And again, the disparities of how that loss happened in terms of our Black and Brown communities. But that loss goes on for a long time. And we have to have services that can work with families that have lost primary caregivers for youth. Just these disparities, you guys know these, so I won't go through them, but they were stark during the pandemic, really stark in terms of mortality. And so the challenges going forward include, how do we deal with this? How do we deal with it? And the first thing that became aware of post-pandemic and pre-pandemic were resource gaps in the care continuum. And that's a big piece of what I'm going to be talking about. It's also workforce issues. There's also parity in terms of what has also become very clear in my position this over the years is the disparate payment systems that we have and how different payers pay in different ways for behavioral health. And then the whole issue of equity and inclusion, which I think we have to keep facing and pushing for harder and harder. And as a state, the key piece of that is how do you incorporate that into your planning? And that's why I just want to spend a minute talking about the way we're trying to think about what you're going to hear, which is $1 billion investment in services, and how we're pushing those out. And one of the key things is to make sure they get to the communities most in need. That is not always easy to do. So we are looking at what data we can get our hands on. But one of the things that we've been doing is working very closely with the Medicaid data, which is one data set that we have, to break it down by race and ethnicity. It's interesting that kind of we haven't. Now, people will say that the data isn't all that great on race and ethnicity, and that's probably true, but it can really give you a direction to go in. So just as an example, this is what we're calling a dashboard that we've given out to our clinics. So I hope your clinics, your Article 31s have it as well. And I hope you're working with it, which is breaking down the core indicators that affect mental health by race and ethnicity. And I think that's just one way to use these the experience of Medicaid claims, which is not the best data system in the world, but to help us start to target areas where there are deficiencies. And this is just one example. We're using it in our planning across the state. We've also had across the state a whole series of listening sessions from in multiple communities across the state, upstate, downstate, to hear what people really think we need to do with some of these dollars that are coming through, because we don't want to do it without the input from the people who are actually receiving the services. So that's just how we're planning for what we think is probably the biggest investment I've ever seen in mental health. And the key overarching goals, integrated care, you guys know this, your physical health, mental health, substance use, and developmental disabilities. It's interesting that our system over time has kind of segregated developmental disabilities off as well. And I think that those have to be incorporated if someone has a dual diagnosis of mental health. We need easy access, we need equity and diversity, and we need the full integration into community life. And peers, which we are using extensively, and you'll hear me talk about that through the system, I think are just critical. I think that they can reach, especially individuals with serious mental illness, far better than often we as providers can. So what do you do with this? Well, it's $1 billion investment that I like to talk about in 3 big buckets. And I think, government often moves in when there's a crisis into a piece of a system. And what I really think we're trying to do here, and what I think our governor is supporting, which I think is pretty impressive, is that it's not just a piece of the system. It's looking at, first of all, prevention. Something that hasn't always been paid as much attention to in mental health. Then access to care when you need it, where you need it, and building an infrastructure where there is more and more of those resources available. And then finally, an intense look at the individuals and families that need intensive help. This is where the gaps in some ways, especially for adults, have been present since deinstitutionalization. We have not put into the community some of the intensive services that can really help people to live those successful lives. And that's resulted in things like increased use of jails for individuals with serious mental illness, where people get into the jails and prisons, where they get into the criminal justice system, and street homeless, which I'm sure, we all our cities across the state. So how do we fill in those gaps and begin to change that scenario that's truly been there for decades. And so that's where I'm going to talk about the complex populations and the investment in providing the community-based services. When you hear the news, and people talk about are seriously mentally ill who are maybe on the streets or in jails and prisons, they always say you need more beds. Yes, we need the right number of beds, but the biggest thing we need are these intensive services to help individuals with serious mental illness live successfully in the community. And that housing is a huge one, which I'll be talking about. Okay, so in the enacted budget in prevention services, I was going to talk about two things that I think are a couple of things that are particularly exciting. The first one is school-based clinics across the state right now, and you run some school-based clinics. We have about 1,000 school-based clinics. There's about 6,000 schools across New York State, so we're not there yet. But we're planning within the next 2 years to double that to another 1,000, and we certainly can take in anybody who wants to do this. So we are working with all the school systems, and we're working with our providers to provide the school-based services. Now, one of the things everybody knows is there's been trouble in making sure that the school-based services are financially viable. And one of the big things that we got through the budget this year was, first of all, an increased rate. So those school-based services are getting a 25% increased rate. But in addition, Medicaid rate, in addition, we got in the legislation that commercial payers have to pay for school-based services, and they have to pay at the Medicaid rate, at least at the Medicaid rate. That will make the vast majority of our school-based services really viable. And it's an important concept, which as I talk about crisis services, I will mention again, this concept that commercial payers have to pay for some things which they have not traditionally paid for, or paid slightly for, or failed to actually get the payment out, even if they accepted the bill. So the reality is, it's very important that, especially for acutely needed services, so for both school-based and also for crisis services, which I'll talk about a little bit later, we have an involvement in commercial payers now on the books that they have to do it. And we also have a huge effort at parity at the state, which sometimes is behind the doors. You don't see it. But just to mention that this issue of adequate coverage and adequate payment is huge, and that basically the work that's being done in parity is very intensive. And New York is one of the states that's working on, we've done a lot in the Medicaid side, and now we're moving into the commercial side. And we're going to also have regulations that will ensure network adequacy in for both commercial and Medicaid as of, I think it's probably 2025. Those regulations will be out. So basically, there's an increased push to make sure that coverage, when you talk about access, there's access on the Medicaid side, which the state is intensely involved in, but we know in behavioral health, there's this big access problem for the lower middle class and individuals who can't pay privately. How do they get in if their insurers are not covering certain services? So this is a big issue. The second, so that's school-based services. We're also going to be integrating substance use and mental health in the school-based services. We've had it pretty much mental health. I've been working very closely with Dr. Cunningham to make sure that the school-based services are going to do some training. They're coming up with some ideas about how we can do that. And we'll be sharing that with all the school-based clinics across the state. The second is the Healthy Steps, which I'm sure your pediatricians are aware of. It's that evidence-based practice that has a mental health professional in a pediatric practice. We've been expanding this across the state. Within 2 years, we think we'll be covering in pediatric practices. Pediatric practices apply to this, so it's available. And basically, I think within 2 years, we want to be covering about 350,000 kids and families across the state. So again, this is an interest in providing the kind of preventive services that are really important. And we decided to emphasize schools and pediatric clinics, schools and clinics. And what I'll talk about a little bit later too is Project Teach, which I hope you guys all use if you need it, which is the availability of consultation free for many child psychiatrists to any pediatrician. And we also recently expanded that to cover issues for maternal health. So we have experts in maternal health who are available to speak with any providers who call, including psychiatrists, but sometimes psychiatrists aren't as aware of some of, for example, the medications that can be used safely during pregnancy. So for maternal health and for pediatricians, there's Project Teach. And then the expansion of mental health first aid, a big investment in doing this, both for adults, the traditional mental health first aid, but now there's something great that's out there called youth mental health first aid. And it really teaches teenagers and young adults about mental health first aid, focused on teens, focused on youth, and really helps them help each other. You know, when we did listening sessions across the state that included some listening sessions with youth, one of the big things that they talked to us about is being there to help each other. And that some of the things they wanted to learn how to be better at that, in addition to having teachers and others be, and other adults be more aware of some of the mental health issues. So we're expanding that also. And then lastly, while it's not never talked about as prevention, but I think it's really important. You know, when you think about the cost of disability for individuals with serious mental illness, we have across the state about a 19% employment rate for individuals with serious mental illness. That's actually pretty terrible. Basically, there's no reason that we couldn't be in the 45 to 50% of employment. And so we have to have a big initiative out there to help providers see the potential of individuals with serious mental illness to work, because that's one of the biggest things that can help the long-term disability and the long-term withdrawal from society. So we're basically working very closely on this. And the governor had actually brought this up, which I thought was terrific. I've rarely ever been around government officials who say, what about employment for you're seriously mentally ill? So we have some dollars in the budget that will support something called IPS, which is an evidence-based approach, and has been very successful in helping to get people, individuals with serious mental illness employed. So we're going to be expanding that, and that's great. So if in your clinics, you see, we can get you information on how you refer, what you do if you don't have this, but your Article 31s should be able to do this work. We're putting out employment specialists, et cetera. So it's really very, very exciting. Okay, now community access. And this is one of the biggest of the community access points. We have had 13 certified community behavioral health centers in the state from the original grant, which was 5 or 6 years ago. They're cost-based, much like your FQHCs. The interesting thing that they said, though, when they put out the legislation was that you couldn't have primary care in, I don't know why, it must have been some political battle, but you couldn't have primary care in these certified community behavioral health centers. Linkage is critical, but you can't actually provide it actually there. It would have to be co-located or something interesting like that. So, but basically, other than that, they should be doing everything. Oh, and the connections have to be tight. We monitor, you know, the success of the health outcomes for the individuals in the certified community behavioral health centers. But the rest of the array of services are expected to kind of pretty much be there. So that includes traditional clinic services, it includes mobile crisis outreach, it includes intensive outpatient, it includes the ability to start intensive integration with substance use and starting that and every other kind of need in terms of medication that substance users may need. So basically, it's a very comprehensive program. And if you come in, you become a member of that community behavioral health center, and the community behavioral health center is kind of watched to make sure that those individuals that they see, what are their hospitalization rates, what are their ER visits, what are their outcomes, et cetera. So the certified community behavior, much like it was modeled after the FQHCs, it's very, very exciting. Now, the feds gave this out on a cost-based basis in the initial round of those initial 13. They then gave grants over the years, about $2 million that went, but the $2 million were just grants. They didn't kind of put in a base ability to finance long-term relative to what the 13 were. So we have a number of expansion sites, which I'll be showing you later, et cetera. But this proposal increases the 13 originals. So it says that we will have 39 funded the way, and the state's picking that up. And the state is also picking up an indigent care pool, so that because certified community have to take in everybody that will support the infrastructure of the CCBHCs. And I'll show you some slides about those later. We're also going to be expanding our basic mental health clinics. Then we have some special things that we're expanding and that will give access. One is home-based community intervention for youth. I mean, one of the things that, again, I think our system has failed at is being quite, especially with youth and families, as able to get into the home and work when there's an intensive need. So that's going to be expanded from about 3,000 to 4,600 slots. We're opening up 12 new CPEPs across the state. I think those are comprehensive psych emergency programs. You probably know this from having referred clients to them. ACT teams, assertive community treatment teams, 42. When I say these numbers, I have to kind of say them because I've never seen this kind of investment. We usually give a little bit here, a little bit there. This 42 ACT teams, each ACT team serves about 69 to 80, depending upon the ACT team. That's a huge, we have 112 now, and we're increasing by 42. So this is a big investment in the kinds of services that are needed in the community. The expansion of intensive sustained engagement teams. These are peer-led teams that we're going to be adding 4 more teams for. And then just to mention that we think of the whole state. So a FarmNet, which is a peer-run program up in the rural areas that works very closely with individuals with serious mental illness in the rural areas, is now being embedded in the budget. For many years, that was just what we call legislative ads, and the funding was precarious. And then there's eating disorder centers across the state that we'll also be funding permanently. And that's also very exciting. I think that in some ways, the really intensive need for eating disorders has not been met as much by our providers or the state. And so I think this adds that. Just want to talk for a minute too about the expansion of telehealth and what we've been doing. And the numbers are just kind of dramatic. You probably know this, but in 2020, before the pandemic, 3% of all Medicaid claims were tele, 3%. By March and April, they had gone up to 90% of behavioral health claims. It was like this flip-flop of things that just went so quickly. And as you know, Dr. Cowan said before, had a significant impact on our ability to provide services, but also taught us, I think, the value of technology, which we were kind of lagging behind with. You know, we weren't kind of seeing in healthcare how valuable this technology could be. Overall, there seems to be a very positive feeling about it. Technology is a challenge in some, it's not sometimes not so much for the clients, but for the areas. Believe it or not, there are dead zones still in New York State, and also just the cost sometimes of, you know, having your cell phone working, having everything working so that you can use some of this. But the utilization of telehealth currently is probably at the 65, 70, 75% range, depending upon where you look. And we don't know if that's going to go down. There's a lot of hybrid work going on for groups, which I think is great. You know, we have our rehab groups, our rehab programs, et cetera, the PROS programs, and they do a lot of hybrid work. So that means that if someone can't make it that day and they have an ability to tune in, they can tune in. And what almost all of our clinics have shown, which I'm pretty sure yours do, is the no-show rate has dropped as we have had the ability to use telehealth. It's really very exciting. And then we fought very hard to get this. So the payment is audio and virtual full clinic rate, and basically the facility fee can't be cut out on the Medicaid side. You know that you get paid facility fee plus, you know, so it can't be. You have to be paid the full rate, and we fought to keep that in Medicaid, and we're going to try to get it legislated on the commercial side, but we had to didn't win that one yet, but we'll keep going for it if we start to find that the insurers are starting to pull back a little bit on the rate because of the facility fee issue. So, I mean, that's something that we'll continue to look at. Now, the certified community health centers, this is where they are. They are all across the state. There are some dead zones, and those are the zones where we will be adding CCBHCs. This is just an overlay of the distressed counties and then where the CCBHCs are. So the other piece we're doing in planning is coming up with putting more of the CCBHCs in the areas that are distressed. You know, when we first did this, it was just come as voluntary. You know, you come forward and say that you want to do it. It was a new model, and there was a lot of interest. But now we're going to be also targeting areas where we'll be saying we want one here, we want one there, we want one where we found that there's an increased need. They basically have had good outcomes. 24% of individuals coming into CCBHCs have never been seen before. So we know we're getting new clients in, which is great. They've had more success with hiring, largely because of the cost-based base. They still have some issues, but issues like everybody, but doing better. The vast majority, 66% of co-occurring disorders, they've decreased, have increased the percentage of each year from use for MAT going up. Significant decrease in behavioral health utilization, both on the medical side and on the behavioral health side. So I think that they are very successful programs. Got the data to show it, which is why we got the increase in the number across the state. When we increase, the current number of 13 are serving about, across the state, about 100,000 individuals. So when we triple it, we'll be serving over 300,000. So we serve across the state now about 900,000 individuals every year. So with these expansions of services, we're thinking about a 300 to 350 ability to increase services across the state for something like this, and then the other myriad of services. So this is a huge investment. Workforce is an issue. I'll get to that a little bit. I know that that is, but the investment, the dollars are there, which are really impressive. So again, the CCBHC's complex needs, including fully integrated care. And this year, we're going to be working with them on working on some training and collaboratives for individuals with developmental disabilities and mental illness, because some of them need specialized care, and the CCBHCs are a great place to do that. And integration with all the crisis services, they have to be connected to our crisis services and peer services throughout. And we're really emphasizing peer services, inpatient, outpatient crisis services throughout the system. Now, the highest need individuals, these are the individuals who have the most serious illness, or some have kind of lost connection to the system of care, don't trust it, and kind of also cycle in and out of hospitals. So you do need a certain number of beds, and you need to have those beds well aligned. So we are putting on another 150 state inpatient beds. That's the biggest increase in state beds probably over the past 20 years. State hospitals have been downsizing. This is a commitment to upsize. But they're going to be specialized beds. So 150 state beds, 100 downstate, 50 upstate, but also an additional 50 downstate, total 200, that are working very specifically with the individuals who have are homeless and really undomiciled, not even the shelters, but the individuals who sadly are on the streets. And we have opened up those 50 beds already at Manhattan Psychiatric Center. And it's been impressive, actually, between that and the safe option support teams that we have in the subway system, and all the other great outreach workers that have been working in the subway system. We've been able to, with our teams, house about 160 people who permanently house 160 individuals who, many of whom had been years and years on the streets. So the reality here is you can engage people, you can work with them with the right model, but you may need an inpatient bed to help with that, and that's what that's about. We're also going to be working with the hospitals on discharge protocols and responsibilities. And if you have a seriously mentally ill population, you may have experienced he went to the ED turned him around, turned him out. He didn't get admitted. Why didn't they? He's still very sick. He's not coming for his appointments. He's not. So we realize there's been a cultural problem with that. There's also been a problem that we haven't had the resources wrapped around the services, and that's what we're going to be doing. We're going to be adding the resources so that those individuals can get better care. And so that's a major initiative here. And that's going to have to be working with the hospitals and the EDs for them to think a bit differently, but also to use the services we're putting up, which are intensive wraparound services, the increase in beds, putting the beds back online, and housing. So this proposal in the budget has 3,500 units of housing, of which 900 will be what we call transitional beds, individuals who are leaving the emergency rooms or the inpatient services, for them to have a safe place to be for several months while they kind of acclimate to being in housing, and then moving on to the graduated housing that we have going forward. In New York State, we have 47,000 currently supported housing units for individuals with serious mental illness. And we do have some that continue to open up through the supported housing initiatives. But these 3,500 are put specifically for individuals with mental illness, and basically give us the opportunity to link them to health services so that we can have transitional beds for individuals who may have not been in housing for a long time and need the skill set. And the other group are the individuals who have some, more complex co-medical problems to get them used to dealing with those before they move into our other levels of housing. So it's exciting to have that kind of commitment to housing. It's huge. We're also increasing those subway teams so that we will be able to really, I think, touch almost all of the individuals who are chronically I hate to use that word, but chronically street homeless, who have serious mental illness. When the HUD people do their survey every year of individuals on the streets of in New York City, let's just take New York City for a minute. They have a category where they judge people to have some serious mental illness, and that number runs every year, even like I think the first year of the pandemic, or we don't have last year's data yet, but runs in the numbers of somewhere between 1,800 and 2,000 individuals with serious mental illness who are on the streets. So, and it's stayed the same. While the homeless population generally is going up, and the individuals in shelters, et cetera, there's been an increase, and there's been an increase in mentally ill. That core group of individuals that seem to be on the streets has stayed kind of the same. So it's a population that we should be able to have a real impact on. So we're hopeful that by adding more of these teams, working with the outreach teams that are there, we will be able to help at least half of those individuals ultimately move into safe housing. And so far, about 160 have. And we're working very hard with the city, et cetera. The safe option support teams are engagement teams. They stay with the person for up to a year or more as they move through the system. And I just have to say that about all these teams we're putting up, the key ingredient, which we all know, but we don't often design things for, is connections. People need connections. And when you think about disconnected individuals from society sometimes, and then we ask them to go from one team to the next team to the next person, you know, your success rate of helping people really move and trust the system goes way down. So with these teams, they really stay with the person pretty much as long as they need to. They're funded by the state, so they can kind of pretty much do whatever they want to have to do. It's not kind of enticed in a billing schema. So it's very exciting work, and we've had some real success, we think, so far in terms of helping individuals get permanently housed and also begin to get on that continuum to permanent housing. They've also brought a number of individuals to the psych emergency rooms and to the medical emergency rooms. I think it's about 400, pretty much evenly split between the two. And they've been able, I mean, there are individuals who are brought in voluntarily, but these teams have been able to get people voluntarily to come for those services, which I think is, again, engagement. Again, it's relationships. So we're really very happy with that. We think it's got real potential. And then for children and families, similar wraparound teams, similar Health Home Plus. And then the last point, which is really exciting, is again getting a Medicaid payment for all the crisis services. All of these crisis services I'm talking about, crisis residence, crisis intensive, crisis, and the payment by commercial payers. But that will happen as of 2025. But that's a big increase in terms of helping to pay for the system, but also in terms of easy access for those individuals who have insurance and their insurers should pay for it. Again, challenging needs, just the individuals who've gotten into the criminal justice system. We're doing a lot of work on prevention of incarceration, diversion, if someone gets in trouble with, to help them not get into jail or prison. We have an interesting program upstate, which is upstate in a very rural area. We have a number of counties where if the police are called out to see someone, they have the ability to have an iPad connection back to a social worker that's connected to one of the hospitals or the CPEPs, and they can have a discussion. They can actually do an evaluation, a virtual evaluation, and they have that security right there. You know, there are not enough staff up in some of these rural areas to have someone go out with a sheriff or even go out initially. So the police, but they have this connection and they found it very, very helpful. We're going to be continuing to expand that. I think it could also be helpful in cities where sometimes you don't have that connection, but it's again a way to use technology in an innovative way so that there's an immediate connection between response teams. It could be used on just EMS going out, et cetera, and some places are using it that way. So technology can be our friend in many, many ways, and I think we need to use it more. And then I just talked about the homeless teams before. But now, the other thing kind of parallel to everything I'm talking about, which came out this year, is the full development of our crisis services system. And the first thing there is 988. 988 is not just a call line, it's a crisis support line. So if an individual calls 988 and they need a referral, that will happen, a referral to mental health. But if they just need to talk to somebody, they can talk to somebody, and time rate on that phone is anywhere, the average call is 20 minutes. So some calls are longer, some calls are shorter, but it's really a crisis line. And big crises and little crises. When I talk about this, I always say it can be a mom who's worried about, geez, how do I talk to my, my youth about drugs? Or I'm worried about my child who's not doing so well in school, all the way to someone who may be the caretaker of someone with serious mental illness who's decompensating. So you can call for all kinds of things to 988. We're working very hard to get it out there so that more of those mental health calls that come to 911 shift to 988. And in some areas in the state, not so much yet in New York City, but they will be working on this. There's been a really nice tight connection between 988 and 911, so that 911 is triaging calls over to 988. And that's what we would like to have. It helps the 911 to be able to do what they need to do, but it also helps individuals get direct mental health services, which is also often what you need. So 988, now, so it's fully funded going forward. That was a big push to get it into the budget, and it is now. Connected to 988 is mobile crisis teams. Mobile crisis teams are being expanded across the state, and then connected to the crisis system are also the crisis stabilization centers, crisis residences, all integrated services with mental health and substance use, and also tremendous peer involvement. We have peer advisory boards for these crisis services, et cetera, because we really need to know that we're serving people well. I'm not going to go through this in detail, but kids are a huge issue. And, we've been building the system for youth and working with families and increasing the ability for youth to have maybe sometimes some temporary respite places. Our crisis respites are increasing, but also building the basic infrastructure of clinic services for youth that need it. We've also been doing a lot of prevention in the schools. And again, I won't go through this, but one of the big things that happened a number of years ago was the passage of a bill in New York State that said mental health education had to happen in schools. I think this was about 6 or 7 years ago. I mean, it's amazing that it wasn't there before, but it wasn't. And basically what we've been doing is working very intensely with the Department of Ed on curriculum, and they have some really great wellness curriculums now that are being pushed out in schools across the state. And if we're ever going to stop stigma, I think if we're ever going to prevent people from being afraid to seek help or worried about it, my book, you start in schools, you start educating people to do this, and you begin to make it part of the culture, and you get to the parents, and you use that as a huge prevention and education opportunity. So that's growing, and I think we're beginning to see changes. And there's also a whole other thing we did was we had some grants for putting specialized, even in more intense mental health services than the traditional school-based in some schools. And that involves a whole school culture move where you do a lot of training of teachers and everything, and you change it into a social emotional wellness plus a school-based clinic. And this is one of the first times with the Department of Ed that we targeted those dollars to high need school districts. So often before, the money would just go out to school districts and say, come as you wish. When you do that, you tend to get responses from the school districts that are a little more affluent and have the ability to request a grant or look at the grant page or aren't so overwhelmed that they can't. So this is, again, as we're pushing out these dollars, we're doing more of this kind of work. So we looked with Department of Ed at their high need school districts, and we specifically said to them, do you want this money? That makes a big difference. That means that you begin to get the dollars where you need to have them. And then there's all other kinds of things we're doing. Early intervention, and mentioned healthy steps, but we also do a tremendous amount of suicide prevention in our schools. And we're going to be also working together with OASIS. OASIS also does a lot of substance use prevention. So when we're in the schools, we're saying, why did we come in? Then you come in. And so we're going to be coming together to figure out how we work with schools together so that there's a kind of a coordinated message. And we're beginning to talk about that and how we do it across the school systems. Again, in kids, expansion of all the clinic-based services, and then also the intensive community care for youth. And that includes intensive outpatient programs, partial programs. And then I mentioned ACT teams, and most of you are probably familiar with ACT teams. What we started about a year ago, and we got more money in this budget, is something called Youth ACT, which is really designed to do something, so not exactly the same as adult, but again, a team that will work with the family, not confined to clinic walls, and that will really provide that kind of intensive linkage for families that need it over the long haul. And so far, we've had very good feedback and success with the 10 Youth Act teams that we put up last year, and we'll be putting up 10 Youth Act teams this year. So it's really a very exciting time to really be thinking about these community-based services, for intensive community-based services for kids. High fidelity wraparound works with the most challenging combination of social and mental health problems. It's an evidence-based practice that gets agencies and everybody together, has a high success rate across the nation, and we're going to be making it statewide. It's done well here in New York State too. You know about our first episode teams. We're almost at the point where the whole state's covered. We're still working on doing it in the rural areas because, and we're going to get a model out soon because, you know, it's not viable just for individuals primarily with schizophrenia in the rural areas because you don't have the population. So what we're doing is maybe incorporating a larger group and now experimenting with incorporating others like individuals with bipolar disorder or severe personality disorders. And then if that works, we will actually use that maybe in some of the other first episode teams. And then home-based crisis intervention, lots of youth. Youth don't need permanent housing, but they need transitional places to be sometimes while we work with the parents and the youth, and we're expanding that, and those transitional beds, those crisis beds, those will be increasing. And also a couple of specialized inpatient units, one upstate at SUNY to work with individuals with developmental disabilities and mental health. And they will then become a hub. That unit should be opening in the fall of this year, and they will become a hub for learning and collaboratives. This has been challenging. If you work in hospital systems, one of the most challenging groups have been the individuals with developmental disabilities and mental health. They get stuck in emergency rooms and they don't fit our system because, quite frankly, I don't know that our system has been well trained enough to really be successful in working with some of these individuals. So we have a unit downstate for adults at Kings County Hospital, actually, which has been doing a very good job and is connected to a step-down residential system with OPW, and it's been doing very well. And we're going to be modeling that upstate for youth. And then what we would like to do eventually is have a unit upstate, downstate of each, so that we could have a nice continuum of services. Let me just go quickly into workforce because this is everybody's concern. I know that the COLA people were advocating for more this year, but I do have to say that we have never had back-to-back COLAs in over 15 years in New York State for our providers. Last year we had a 5.4, this year we got 4%. So it is a significant investment. The other significant investment has been the continuing rate increases in ambulatory and inpatient services and housing, put to 104 million, because these are other ways that we support the service system. And some of those increases in rates were, you know, initially because of the federal money that came. And there was big federal money that came in the various acts to help out during the pandemic, but it was one-shot money. But the state is committed to continue those rates. So I think that's where there's been an increased investment, which is ongoing, even though I know that people are still struggling with recruitment. And then we have a loan repayment program. And I really want people, I hope people are aware of this, but the loan repayment program is definitely applicable to all your services. The loan repayment program for physicians and nurse practitioners was $9 million. We've spent about 60% of those dollars, but there are dollars still there. And you get loan repayment in return for spending a certain amount of time working in a public services. So keep that in mind. Keep that in mind. This year we got $5 million to do that loan repayment for social workers and psychologists and school and mental health counselors. So this is good money here that you can apply for. The second one isn't out yet. The physicians and nurse practitioners is out. You can just check on our website. You can deal with it. The other one should be out in July. And that should be very helpful, hopefully, in terms of recruiting social workers, et cetera. If they give, I forget the exact number of years and the payment, but for the payment for their loans, they said spend so many, they get years working with us or with you. And that's a real positive thing. So basically, this is one way that we've been working with trying to move the workforce. The other is training and support. You know, people sometimes work someplace because it's a learning experience. And we have often not had the time, or some of our clinics don't have the money to invest in this. So there's a couple of things we do. So for social work, we have, this one is where we work with all the social work schools across the state. It'll be expanded to all the schools. It's a small stipend. I don't know if it's $500, a little bit more, but they get the experience of working somewhere in their last year of social work on an evidence-based practice in a behavioral health clinic somewhere. And they get a small stipend for it, and they get the experience of doing that. That's been very successful in getting people to come into mental health. The other is we'll be financing, and we're trying this out with kids first. Mental health is a specialized family treatment system. I forget what it's called, family therapeutic service, something like that. It's got an acronym. That's actually one of the best evidence-based practices for youth and families, but it's copyrighted. So you've got to pay the people who developed it if you're going to do it evidence-based. And then it involves a lot of supervision and training time. So we're going to be funding that for a number of sites across the state because big clinics wouldn't have been able to. And we are going to, there's an RFP coming out for that. We'll be asking people to join and work with us. So it's a way, and we're going to try that out. And that might be another way to maintain keeping people in the system, because they get something in addition to, just they get a learning experience that goes on. And then we're also working with SUNY and CUNY on scholarships. We have money for scholarships, especially for diverse students, et cetera. And then the last point on the workforce development is I think we have to think wider about who comprises the workforce. And so we had put into the budget, we lost this one, something called a qualified mental health associate, which was going to be kind of somewhat like a CASAC. Scope of practice issues got involved, and sometimes you don't win those. But DOH did win a community liaison worker. And we're going to see if that title, which is a paraprofessional title, could be utilized on the behavioral health side, and we think it can. And that will help us. We would love to set up a training program that would certify people if they're not licensed. They would work then as assistants to licensed professionals like social workers and psychologists, and be able to expand the work that they do, kind of maybe some mental health coaching, maybe some follow-up, whatever, that they could be utilized in our clinic system and get paid by Medicaid. So that's one way to expand the scope. And we've done this with docs, where we have others who, physician assistants, for example, that help doctors work at their the highest level, and then the physician assistants. And I think we can do this with social workers and psychologists, et cetera. And so we're planning on running that out, that I think might be helpful, because I don't know that we're ever going to have enough licensed professionals. The other good thing about the paraprofessionals is many of them come from the communities and are diverse. And we would also like to make sure then that we had opportunities for them to go to advance in the field. So if we can get this through, we would then try some scholarships and things to that as well. So if individuals came and did this work, they would have the opportunity to advance and not just kind of be only at that level if they wanted to. They don't want to, that wouldn't be. So that's where we are with workforce. And we're open to any other ideas or suggestions. When we had all the federal money, we gave that out for people to give bonuses and retention bonuses. That's not as, some of that money is still floating around. But those kinds of things are things that we want to keep looking at in terms of enticing people to work in the behavioral health field. So I'll stop there. If there's any questions or comments.
Yeah, thank you so much, Dr. Sullivan. We do have a few questions, so I can just read them out. The first one is from Miriam Ford. Lots of great programs and initiatives. Staffing and housing seems like the biggest issue. Is the state considering loan repayment programs? So I think we did touch on this for providers willing to get psych education, postmasters, psych nurse practitioner, for example. So I think we address that.
Yeah, and please get the word out, because we still have dollars that we can spend on this, and we would really want to spend them. You've got to spend them, guys. If you don't spend the money, then when the going gets rough, the state says, oh, you didn't spend that money, maybe you don't need it. So we really need to get the word out, and it's a very easy application process. It's not very cumbersome. So if staff want to, please let us know.
And also related to loan repayment, we have a question from Dr. Kusel. Does the loan repayment program apply to primary care physicians?
No, not this
that
one. And now, wait a minute, there is one on the DOH side that
Yes,
applies
of
to
course.
primary care physicians. Not this one. This is specific for psychiatrists and practitioners, but DOH has one. So you can check that one out.
So I have a question for you while we're looking at these other questions. So you're familiar with the work that we do. If we wanted to expand the scope of our services, what would you think the first step should be? I mean, right now we do a lot of traditional services. By the way, we do have 3,000 developmentally disabled patients in our midst. So that's that's an area that we're really looking to. We took over 2 access programs, one in Ulster County and one in the city, that were sort of failing financially. But where is, we've talked about the CCBHC program. Is that something that we should be considering? What would you think for an organization like ours would be an area where we could expand our scope of services in behavioral health?
Yeah, I think, to the extent that you have, I think you definitely look at CCBHCs. Absolutely. I think that as a funding model, et cetera. The other is I'm not sure if you, in your clinic, your co-located clinics, if you do much intensive outpatient.
We do not do IOP, Dr. Sullivan.
No.
You should think about that. The reason is that when you have your more challenging patients, the ones that maybe your people are seeing that have SMI, that are the intensive outpatient pays you better. You can do multiple services on a day, and you can really help stabilize people. So I think the intensive outpatient, most places that have put it up for both adults and kids, and it's a good model for kids, have found it helpful and successful, and it kind of pays pretty well. It enables you to do, to really give comprehensive services. So one thing I would look at is definitely, intensive outpatient, as well as the CCBHCs. And then the other thing to think about, and again, did you say that do you have some ACT teams connected to you, or?
We do not operate any ACT
We
teams.
don't.
You got to think about that. I don't know if that fits in, but you do connect with crisis, right? You have crisis?
Not directly.
Not directly, but we can maybe work with you on some of those in terms of, if you don't run them, at least, better connections. But those are also the kinds of services that our clinics do that they find really helpful for the higher need, clients. So I'm talking about the higher need. The other thing I think we would love to work with you on, but it would probably take us a while to get it organized, is this community liaison worker, and seeing, because this is where you've got a lot of ability perhaps to expand what you can do and get paid for it by Medicaid. And I think you've got the infrastructure to do that in a way that some other places don't. So we would love, sadly, we lost what we proposed, but we're going to work on it. So I think that's something that we would love to talk with you about across your systems, try it, to pilot it in certain places. What would work there? And then the other thing, depending on if you're having clients that are getting lost or disconnected, do you use peers much? That's another title, group of people, where individuals with lived experience, they can be tremendously helpful. And especially with families, one thing is, when I think about your system, here, family advocates are really great in terms of helping families get the services they need, helping them understand if there's not just mental health, but the complex needs of families. And sometimes they can be really helpful to be present in a clinic. And you call them and you say, work with this family. This family's under a lot of stress for all these things. They help connect them to our, the various social determinacy services, as well as, work with them on the mental health side. So people with lived experience who are trained, and they're all trained. If you hire someone like this, they've got peer certification or they've got family advocacy certification. They can be very helpful in clinic settings with the complex. When you have someone you really, I don't know how to help. I mean, it just seems so big. They can be very helpful, and they carry caseload and do things, and they're billable. They're billable. We got that through Medicaid, that peer services are now billable in
Wow.
in the clinics.
That's very helpful. We will definitely follow up with you on some of these things so that we can see which ones, are practical for us, and things that we could do. But we definitely recognize the need and are very interested in playing a larger role if we can. There are a couple more questions in the chat. Lots of great programs. Staffing is we have that. So what's being done to streamline processes for getting people connected to services such as supportive mental health, front door program with the OPWDD? In my experience, they have significant wait times, extensive applications that require multiple evaluations, cause a huge administrative burden. And in the case of OPWDD, patients are required to find their own neuropsychological testing, which is long waits and financial and language barriers.
Yeah, I know the commissioner at OPWDD, and we're working very close together. I mean, you're absolutely right. There are all kinds of obstacles in terms where we're trying to break down. Some of it is with the high need, with getting people. We're going to be working on it, let me just say, with the CCBHCs in terms of immediate access. Whether we have to do a dual license, I don't think so. I think mental health clinics, and let me stay with the not the intensity treatment, but like mental health clinics can do a tremendous amount of work with individuals with dual diagnosis. I think the reason we haven't is because, I mean, it's not forbidden, it's not anything, it's just because people aren't trained to do it and they don't know how to do it. So I think what we're going to be working with OPWDD on is a collaborative across the state, and working first with intensively with the CCBHCs, but with others, so that we can expand that training. Because if you have a mental health diagnosis and you're developmentally disabled, you could be treated in our clinics. You don't need a dual license, but you do need people who know what to do. And so I think that's one thing that's really important. On the more intensive side, we're working to try to come up with, and I think we'll be able to do this with the transitional housing, housing where individuals will probably be on the mental health side. So we would pay for the housing and the training and have people who would work with individuals with developmental disabilities, but then OPWDD, by housing, I mean, or transitional housing. And then with OPWDD to do the permanent move, whether it's back to the family or back to housing, where people seem to get stuck when we've looked at the system, and the frustration is that there's nothing in between. You have to go through the whole OPWDD process to finally get it. It takes forever. You can't get it. What do you do meanwhile? You sit in an emergency room. What do you do meanwhile? You sit in a hospital inpatient bed, or with a frustrated family. So if we can set up a way that we can have this transitional housing, which will probably sit on our side with OPWDD assistance, but then move out, you give people several months to do that kind of thing without sitting in an inappropriate setting where you're not getting what you need. So that's something that we're planning, that will take a little time, but that is something that we will be doing soon. The other are these two high-end inpatient units, which connect to step down and outpatient services. And that's for the most severely impacted individuals. And they're going to be learning hubs. So they will be setting up, they will be available for consultation. The one downstate, which has been operating, consults with people all the time. So they're available for consultation and learning, as well as providing the service. So yes, this is a thorny issue. And I think we're working very closely with OPWDD. We should be, let me just say, we should be able to solve this. Why? It's not a huge number. This is not the individuals who are most challenged with this. It's probably several hundred people a year. And we have to make our system respond to them. But then there's the base clinic system and the base treatment system that needs to be better educated and better able to serve this population.
I think we have one last question. Is there anything special being done around the influx of refugees now, and especially being able to deliver services in multiple languages? We even have problems getting Spanish speaking, providers. Any special efforts in that area?
Yeah, well, we're working very closely with the counties. So the counties, you know, wherever right now it's New York City. So we're working very closely with New York City on the issues with the migrants and getting them, you know, into services. It's, you know, you have to work with, this is something we work very closely. We're there to be helpful. We're there to assist. The language issues are severe. I think, you know, we have this telephone language system that everybody can use, but it's not the most helpful. I think that's where I think we should be pulling in to our system of care, these paraprofessionals who can help us. They shouldn't just be translators, but I mean, they could be helpful in working with these individuals, and also people with lived experience of having come here as migrants or from other countries. I think it's very important. You know, these individuals are coming and they need people who are working with them. So yeah, we're working very closely with the city on trying to resolve some of those issues. But the presses of individuals is significant at this point in time. I believe it's like almost in the 50,000s of individuals who are currently housed as migrants. And some are moving upstate now, so we're working with those counties as well.
So we're out of time, but I want to thank you. And, you know, I'm sure everybody's as impressed as I am. It's so incredible to have somebody in such a senior leadership position who's got such a depth of knowledge at the ground level of everything, and really just thinking through how we solve problems for patients instead of sort of this top-down thinking that we always see, but really just thinking, you know, sort of from the bottom up, here are the people, what do we need for these groups of people to really serve them better? And just can't thank you enough for your leadership in that area, and you're really inspirational. So thank you. And we look forward to following up with you. We really do want to see where we can do more. And,
Well, I'd love to work together with you. I mean, you are really a backbone of, you know, I mean, we have a mental health system that I've been talking about, but where most people, they go to you. So I think we can, you know, anything we can do to assist with that, we're there for. And I think that you just do such wonderful work, and your spirit of involving integrated care is just fantastic. It's been there for decades. So that's why it's great. So thank you so much for everything that you do.
appreciate you. Bye-bye.
Bye-bye.
Thank you.